attending. Okay, Shankar, off to you.
Thank you very much. Professor Loblaw, it's a real pleasure to be here tonight and your morning. Obviously, it's an honour to be presenting to you at Sunnybrook and around in Canada. So my brief is to talk about the role of stereotactic ablative body radiotherapy, as I call it SABR, or SBRT, for primary and oligometastatic RCC. The teaching objectives for this lecture are to look at radiobiology and the background of RCC. I'll also be talking about the oncological and renal function outcomes that we expect in primary RCC, and to also look at special populations such as T1B and greater tumours, SABR in solitary kidneys, and the use in IVC thrombus. Then I'm going to be switching tack and looking at some outcomes in the use of SBRT or SABR for oligometastatic disease, the oligoprogressive setting, and functional imaging in oligometastatic RCC. So just as a background for the actual incidence of RCC, this is a disease that is growing in incidence. It's expected to be one of the fastest increasing cancers over the next 20 years. The incidence is increasing in North America, Europe, and Asia. And these are the expected numbers at the total number of cases at present. Asia has 36% and Europe has 32%, quite a lot in North America as well. The greatest incidence is in patients who are greater than 70 years old. And elderly patients are at greater risk of cancer-specific mortality, up to 3.8-fold, and therefore age, frailty, and medical comorbidities that preclude surgical or percutaneous interventions are really going to be a population that need special attention for an unmet need for treatments. In that context, primary RCC has several nephron-sparing options. These include partial nephrectomy, but this requires a general anesthetic. It has the ability to treat perihilar tumors and larger tumors, but it is still invasive. Cryotherapy typically can be delivered either without a general anesthetic, but can require a general anesthetic as well. It doesn't, however, have the ability to treat perihilar tumors, larger tumors, and non-invasive, and it is invasive as well, similar to RFA. In this context, SBRT or SABR may actually tick all of the boxes. It doesn't need an anesthetic, it can treat perihilar tumors, larger tumors, and is non-invasive. There is, however, a general conception that renal cell carcinoma is radioresistant. And this is largely thought to be from older studies that were looking at the use of external beam radiotherapy, particularly in the context of primary RCC in the adjuvant setting. This is a meta-analysis of 7 randomized controlled trials treated with post-operative radiotherapy. Not surprisingly, the pooled results showed a reduction in local regional failure, but no difference in overall survival or disease-free survival with this approach. And one can imagine that older techniques in the 1980s, where these studies were conducted, had higher rates of complications. This is an example of a 3-fill technique from the 80s from the Finson Institute. And one of the issues with a post-nephrectomy bed is a small bowel falls into that nephrectomy bed, and therefore radiotherapy can be potentially toxic for this organ. So how do we know that renal cell carcinoma is radioresistant? It's considered resistant to conventional radiotherapy, and this may be because elegantly displayed by some colleagues in Stanford who did a clonogenic cell assay with the 2 most common renal cell carcinoma cell lines. This is the A498 human renal cell carcinoma cell line and the CARCI1 human renal cell carcinoma cell line. This is a cell survival curve looking at the dose in radiotherapy on the x-axis and the logarithmic surviving cell fraction on the y-axis. When we're looking at small fractions of cell kill, we only see small fractions of cell kill at doses less than 2 gray per fraction, and this is demonstrated by the shoulder in that cell survival curve. However, at doses greater than 6 gray per fraction, the logarithm there, we see some logarithmic cell kill, and therefore it may just be a factor of using conventional doses of radiation that is considered radioresistant rather than hypofractionated or larger doses per fraction. We're also able to potentially understand different mechanisms of cell kill with high dose radiation rather than the typical mitotic catastrophe. This includes alternative cell kill mechanisms, including endothelial apoptosis, ceramide and sphingomyelinase-induced cell death, and a pro-inflammatory signaling for adaptive immunity. The timeline of SABR for primary renal cell carcinoma is actually surprisingly long. This is a bit of a schematic from one of the papers we produced in Nature Reviews Urology. And in fact, the first reports of fixed frame SABR were coming from the Karolinska Institute in Sweden in 1995. Shortly after this, there was some data using a CyberKnife model in Cleveland, addressing a porcine model and CyberKnife. And the first reports of using SABR in primary RCC was actually from the Karolinska Institute in 2003, some 20 years ago. The first reports of using SBRT in RCC in the functionally solitary kidney was in 2008, again from the Karolinska Institute. Our own program at Peter Mac, we began in 2012. And the IROC consortium, which stands for the International Radiosurgery Oncology Consortium for the Kidney, produced a consensus statement in 2016, which tried to marry up some of the international organizations that were currently conducting SBRT at the time to give a consensus approach on treatment. Very recently, the IROC group, including some of your colleagues from Sunnybrook, did actually produce 5-year outcome data in the Lancet Oncology in December of last year, looking at the pooled individual patient data meta-analysis from institutions around the world. In total, there were institutions that were involved from North America, from Australia, from Japan, from Germany, and Canada. And these groups pulled into 190 patients with a median follow-up of 5 years. The average age of patients that we are treating with SBRT is 74 years old. This is different from the average age that's treated by surgery, which is about 65. There was a preponderance of males with 73%, and most patients had good performance status. 3/4 of the patients were medically inoperable, and this is an important factor. And pathological confirmation rates were very high. This is what we expect normally in the thermal ablation literature as well as the surgical literature. A pre-treatment biopsy confirmation is 80% or lower. Interestingly, also the maximal tumor dimension was larger than we see in the thermal ablation population at 4.2 centimeters, and roughly 1/3 of patients had a solitary kidney. In terms of results from the Lancet Oncology publication, there was grade 1 to 2 toxicity in 36% of patients with no grade 3 toxicities reported. One patient had a grade 4 gastritis and a grade 4 bowel toxicity that was reported at 1.4 months and 15.8 months. This particular patient was alive 8.8 years later without any evidence of disease. The results from a cancer-specific survival at 5 years, we observed a 92% cancer-specific survival. The middle graph and the right graph are cumulative incidence of failure graphs, and the cumulative incidence of failure at 5 years from a local perspective was 5.5%, and from a distant perspective was 10.8%. From a distant perspective, this is what we expect from T1B tumors, and this is on average T1B tumors, so that's not very different from the surgical literature. Importantly, one of the trifectas from a surgical perspective is renal function. These patients had baseline chronic kidney disease with an average eGFR of 58.9. So on average, most patients had chronic kidney disease class 3B already prior to treatment with SABR. The mean loss of eGFR at 1 year was 7.2 mils per minute. There's actually a plateau at around about 2 years, and this results in the mean loss in eGFR of 2 to 3 years around about 10.8, which is what we normally expect in this group. And then beyond that, looking at 5 years, the loss in eGFR was 13.5 mils per minute. I suspect that late drop is just in line with the background incidence of chronic kidney disease for other comorbidities such as hypertension, diabetes, etc., that was prevalent in this cohort. In total, 7 patients underwent dialysis at a 3.7% rate. And these patients had a mean eGFR of 28.1 mils per minute. So I think a take-home message would be those patients with an eGFR of less than 30, so in other words, CKD class 4, are potentially at risk of dialysis. So it has to be a little bit more careful. Routinely in my practice, I would always make sure that these patients get referred to a specialist nephrologist physician to maximize the renal function in that context. From a tumor size perspective, 95 patients or 50% had tumors less than 4 centimeters, and the other half had tumors greater than 4 centimeters. So the median size of the T1A tumors was 2.84 centimeters, and the T1B tumors being 4.8 centimeters. On multivariable analysis, per 1 centimeter increase in tumor size, this was associated with reduced cancer-specific survival and reduced progression-free survival. However, this was not significant for local failure, perhaps suggesting that the local efficacy is pretty similar, but this is a prognostic feature. Also, when split by T1A, so 4 centimeters or greater, and T1B, there was no difference in cancer-specific survival, progression-free survival, or local failure rate. And these are the two Kaplan-Meier graphs that are on the bottom left and bottom right, looking at cancer-specific survival and local failure split by T1A and T1B. Now, one intriguing thing that we did see in this Lancet Oncology publication is that the single versus multi-fraction groups seem to be different. There were 81 patients, or 42% of patients, that received single fraction SBRT. And most commonly, this was between 25 gray and 26 gray. So that was 86% of the patients, a pretty uniform or homogeneous population. Single fraction SABR was associated with reduced local failure rate and reduced progression-free survival, but not cancer-specific survival. On multivariable analysis, there was an observation of increased local failure for those patients receiving multi-fraction SABR. So these are three Kaplan-Meier graphs. On the bottom left, this is cancer-specific survival. In the middle is progression-free survival. On the right, this is cumulative incidence of local failure. These are all different between, except for cancer-specific survival. These different from the single fraction and multi-fraction arm. Now, this is hypothesis generating, and I think this is worth testing in a prospective trial. So the take-home message is we observed a 5-year local failure rate of 5.5% in a patient cohort of 190 patients with larger renal masses. This is at 4.2 centimeters, and we typically be able to treat with thermal ablation. These outcomes are comparable with other modalities, particularly when comparing for small renal masses. The 5-year local control rates for partial nephrectomy, RFA, and cryoablation are typically reported between 95% and 97%. In a population with baseline kidney disease, mean CKD class 3, we observed a clinically acceptable 5-year renal function reduction at a mean loss of 13.5 mils per minute or 3.7% rate of dialysis. These recent results are very concordant with a previous meta-analysis that was published in 2019. This is largely retrospective data, but you can see that consistently the local control rates are reported to be quite high. When you pull all these local control rates, it's 97.2%. Up the top, though, there are some cohorts with lower local control, largely in the context of treating patients who have established metastatic disease and are receiving systemic therapy with large tumors. And that's in particular the Korea paper and other papers right near the top. We discussed briefly renal function, and this is one of the key aspects of trying to achieve that trifecta that urologists talk about in terms of complications, local control, and renal function outcomes. One particular aspect is how to control dose. So this is an early observation that we had in a single patient with a solitary kidney treated with a mid-pole endophytic RCC. Using repeated technetium-99 DMSA SPECT CT, we were able to observe that there is a visually apparent loss in renal parenchyma uptake of the tracer at later time points. It doesn't seem to be an issue within the first 3 months, but a year and beyond, we do see dose-dependent loss in renal function in the high-dose regions. In our first prospective clinical trial of PETAMAC, which is called Fast Track, we were actually repeating these multiple time point DMSA SPECT CTs. In this cohort, we also did calculated renal function tests, which is chromium-51 EDTA calculated GFR. This is the gold standard test for a GFR. It takes about 4 hours per patient. So this particular GFR calculation with calculated GFR showed a mean GFR of 55 mils per minute at baseline, and at 1 year, this loss was 11 mils per minute and was stable again at 2 years which is consistent with what we've seen in the literature, including the IROC group dataset. There's no patient in this group that underwent dialysis, but if you look at these serial DMSA SPECT CTs in the below, there is the patient who's been treated with a 7 centimeter lower pole primary RCC. And in the first early time points, particularly at 2 weeks and 3 months, there's minimal loss of renal function within the treated high dose region. But at later time points, such as 16 months, we can see there's a bite-sized area that's been taken out of that kidney function in the kidney parenchyma. And this is consistent with what we see in loss of the renal function in the high dose regions treating with primary RCC. So the take home from this is you probably have to be careful about the high dose regions. When we looked at this fast track cohort, and this was 32 patients in the initial study at Peter Mac, we had 2 different dose fractionation schedules, one which is 26 gray in 1 fraction and 42 gray in 3 fractions for larger tumors. This is individual renal function per dose bin that was calculated and changed from baseline to late renal function. On the top left, it's 26 gray in 1 fraction. In the middle, it's 42 gray in 3 fractions. On the right, it's a biologically equivalent, biological effective dose. What we're able to observe is that when we equate both of these treatment approaches, both single fraction and 42 and 3 fractions, which is isoeffective from a tumor perspective, we see the similar pattern in loss of renal function. There appears to be a rapid loss of renal function up to a biological equivalent dose of 100 gray. And beyond that, there seems to be a plateau. In other words, there's a super lethal region at high dose areas. And so the most amount of gain in terms of preserving renal function can be in the intermediate dose wash. So I think one message there is try to be as conformal as possible with that 50% or the intermediate dose wash. The super lethal area, the 100%, 100 gray and above, we probably can't really do very much about. So in that area, it's really just about treating the tumor. One of the major challenges we find is in terms of response assessment. And one thing that we know when we treat for an RCC is that these tumors take a long time to respond. These are 2 different spider plots, one from a group in Cleveland and another group from Japan on the right. And this is showing that if you follow these spider plots over time, there are patients who are tipping into partial response categories. Now, there's less than 30% of the tumor size, many years post the SABR delivery. And this is something that we have to be really conscious of when following these patients up. Another enhancement is a real issue as well, because that is a measure of success looking at thermal ablation. CT contrast enhancement is not very useful in the context of SABR. This is a study looking at 42 patients. On the left-hand side is a waterfall plot that shows that there is decrease in the tumor size. On the right-hand side, it shows contrast enhancement, and pre-treatment being the dark black line and post-treatment being the gray line. In fact, post-treatment, there's increased contrast enhancement in the corticomedullary phase, the early nephrogenic phase, and the late nephrogenic phase in all of these aspects. So really looking at contrast enhancement is not useful in the context of SBRT as it is in thermal ablation. This is an example of a patient of mine, in fact, who received a single fraction of 26 gray for a primary RCC less than 4 centimeters. It was a T1A tumor. At baseline, there's on the top left, there is a coronal view. In the middle view panels, these are axial views. At baseline, 3 to 5 years post-treatment, if you put calipers across this tumor size, it would measure roughly the same. However, clearly there's some hollowing out. There's an appearance of a tumor carcass, and there's loss of the renal parenchyma of the tumor as well. That's also consistent at 7 years. So using pure RECIST criteria may not be the best measure looking at post-treatment response, but we do need to find a better way of assessing this issue. Right, let's have a look at special populations in the context of SBRT or SABR for primary RCC. One interesting area is looking at the issue of IVC thrombus. This is a very vexatious issue in clinical management because these patients with IVC thrombus do really poorly. There's an interesting phase 2 study looking at UT Southwestern. This was published recently with a safety lead-in of 6 patients. And the main aspect of this safety lead-in was looking at the toxicity of treating tumor thrombus, particularly large tumor thrombus, with large doses of SBRT. Importantly, no grade 4 or grade 5 events were recorded, and these patients went on to surgery, and no preoperative grade 3 adverse events were reported, and there was a 3% grade 3 postoperative adverse event reporting, which is consistent with what we'd expect with patients who have IVC thrombus in the first place. So this is an intriguing area and potentially an area of interest for application of SBRT. Patients with a solitary kidney pose a unique challenge for treatment. Many of the other treatment modalities have their own issues. SBRT may be particularly interesting as a treatment modality. One of the publications from IROC compared those patients with a solitary kidney, in this case 81, compared to 142 with 2 kidneys. And the main issue is looking at renal function. Those patients with a solitary kidney, in fact, had a loss of renal function of 5.8 mils per minute, just similar to those with bilateral kidneys with 5.3 mils per minute. But in fact, fewer of these patients underwent dialysis. This is largely because patients with a solitary kidney are often younger and less comorbid and have had a nephrectomy in the past, as compared to those patients with bilateral kidneys who are often not surgical candidates because of comorbidity and might potentially have other pre-existing conditions which can lead to renal function decline. So all of what I've said, SABR seems really great, right? Like, how do we compare to other approaches? And this is a nice little loony cartoon. Did you read my paper on confirmation bias? Yes, but it only proved what I already knew. So when we look at thermal ablation series, these are selected long-term outcome reports in the thermal ablation series. There's no prospective trial yet for thermal ablation, and this is an important issue because there are half a dozen trials in the context of SBRT or SABR, but there really is not a part of the data in the context of thermal ablation. These studies looked at several different groups, but I'd like to highlight the issue that in RFA cryoablation, the average tumor size is much more than what we treat SBRT or SABR. This is usually 1.9 centimeters, 2.9 centimeters. It's not in the 4.5 centimeter range treating. These studies do have a longer follow-up, and the local control rates, what we see with SABR, around about the 95% mark. And the cancer-specific survival is excellent in this group, reflecting a less comorbid population. If you look at future directions for SBRT, at our institution, we've opened a study called NAPSTR, which stands for neoadjuvant pembrolizumab and stereotactic radiotherapy. This is a study looking at patients undergoing surgery for high-risk intact renal cell carcinoma, T1B to T3 disease, or having node-positive disease or low-volume oligometastases. These patients undergo SBRT with 42 gray 3 fractions and then 3 cycles of pembrolizumab or just SABR alone, leading to nephrectomy and then a short-term follow-up. This is a small study, but looking at some of the translational outcomes from these 2 treatment approaches. Other future aspects, I'd like to highlight the IROC registry. Now, this is an international consortium, and we're looking at enrolling multiple sites for a prospective registry. Prospective registry will really lead to important real-world data on this approach and enable a registry platform randomized trials for planning in the future. Okay, let's talk to Sunnybrook without highlighting the Aquas 2 study, which obviously has been led by and colleagues, and something we're eagerly awaiting. In Australia, the trial group, as the Radiobiological group, have fast track 2, which is the 1503 trial. The study is fully recruited. There were 1,600 mutually exclusive patients, 680 with extracranial metastasis, and 923 with intracranial metastasis, and almost 4,000 lesions treated. Importantly, there's consistent local control with either intracranial or extracranial approaches in the context of stereotactic radiotherapy, really just lending idea that using these high doses per fraction, we're getting excellent local control rates in the order of 90%. This is translated to guideline recommendations in the oligometastatic 2021 NCCN guidelines do have this for stereotactic radiotherapy as recommended options for either clear cell or non-clear cell histology in the context of oligometastatic disease. Finally, I was grateful to be involved in the ASCO guideline for advanced renal cell carcinoma, which is now for the first time in 2022 recommended the use of ablative radiotherapy as an option for patients with low volume metastatic disease. So what do we know from prospective trials of SABR in oligometastatic disease? SABR has been investigated in 3 scenarios. One is in the lieu of systemic therapy. Secondly, is to delay the next line of systemic therapy in oligoprogressive disease. And thirdly, for safety and efficacy when combined with immunotherapy. So the first approach I'd like to highlight is the use of radiotherapy in lieu of systemic therapy. And this is a publication from MD Anderson that looked at a single-arm group of 30 patients with a median follow-up of 18 months. This is a highly selected population with a median number of metastases. The main findings were there was a 1-year progression-free survival of 64% with a median progression-free survival of 22.7 months. The 1-year systemic therapy-free rate, which is the primary endpoint for this study, was 82%. From an oligoprogressive disease perspective, this is a scenario when we have an otherwise effective systemic therapy that is controlling multiple sites of disease. However, there are areas that are escaping control of this systemic therapy that may be addressable by local therapeutic approaches such as SBRT. I'd have to highlight Patrick Chung's work from Sunnybrook, which is a multi-center study published in European Urology in 2021, which looked at 37 patients with 1 to 3 oligoprogressive metastasis. With the use of SBRT in this approach, the 1-year local control rate was 93%, and the median progression-free survival was 9.3 months. The median time to switching drug therapy was 12 months, which is really important in this patient cohort, and there was no grade 3 to grade 5 toxicities. These findings are remarkably similar to a second study from UT Southwestern, which had 20 patients with 1 to 3 oligoprogressive mets. The 1-year local control rate again was excellent at 100% and a similar time to switching drug therapy at almost a year. There's 1 grade 3 toxicity reported in that group. Now we're switching from the TKI era to the immunotherapy era, and we have to really ask the question, is SABR or SBRT really useful, or is it totally redundant in this context? But I like to argue that the use of SBRT is actually synergistic in the context of checkpoint blockade inhibitors. This is an example of a patient on the left panel. We're talking on the top left, it's a MIP image in FDG PET, and on the right, it's a PSMA PET of a patient who has clear cell carcinoma with sarcomatoid differentiation. The FDG PET shows a biopsy confirmed sarcomatoid variant in the lung, and which also a metastasis in the renal bed, which was mildly FDG avid. The PSMA PET scan on the right shows that this sarcomatoid metastasis was not PSMA avid, but the biopsy confirmed clear cell recurrence in the renal bed was more avid in PSMA. Looking at the treatment with a single fraction of 20 gray and pembrolizumab, at even a short time interval, 3 months post-SABR, we're seeing dramatic responses in these large mass within the kidney. This is not the type of response that we would typically see in the lung. We often wait quite a long time to see radiological responses in the lung. So clearly, I think this demonstrates that there is a synergy between immunotherapy and radiation, at least from a local perspective. This particular patient had a T3B primary RCC, which is 85 millimeters in size, resected in January 2015. The secretus right lung metastasis was also resected, and a further 2 lung metastases received SABR in 2015. This patient had an isolated left adrenal metastasis in 2016, and raises the question, are these too many metastases to be chasing with local therapies? Our own institution recently published this data in the Red Journal, looking at 401 patients with 530 oligometastasis. This is a basket histology study, but a decent median follow-up of 3 years. With the use of stereotactic radiotherapy in this context, the median time to initiating systemic therapy was 2 years. And importantly, when we look at total metastatic ablation, which is, I think, is more important than being asked to eradicate just one side of disease, just looks a bit pesky. Total metastatic ablation is prognostic for both overall survival and progression-free survival. So I think whenever possible, try to ablate all sites of disease. This patient with the adrenal metastasis also had an FDG PET and PSMA PET at the time of this presentation. The FDG was low avidity within that area, and the PSMA on the bottom right shows very high activity, which is consistent with clear cell RCC. This patient had SABR to the lung, and the PSMA PET scan on the left-hand side shows there's no activity with the adrenal area. In the middle panel, that demonstrates that after the lung SABR, this patient did develop this adrenal metastasis, and this was confirmed on the PSMA PET scan. And after a single fraction of SBRT to this area, this post-response assessment scan some 3 months later shows a pretty remarkable response within that area. There's still some morphological appearance with some bulky adrenal there, but there's a functional response in that area. Our group did publish a trial called RAPPORT, which stands for Stereotactic Radiotherapy and Short Course Pembrolizumab for Oligometastatic Renal Cell Carcinoma. This study, we were very lucky to get the front cover of the premier surgical journal in urology, and we're also awarded the EAU Best Scientific Paper that was just presented a few months ago in Milan. So this study investigated the use of stereotactic radiation and anti-PD-1 immunotherapy. So the population were patients with up to 2 lines of prior systemic therapy with 1 to 5 oligometastasis from clear cell RCC. The intervention was a single fraction of 20 gray or 30 gray in 10 fractions of conventional radiotherapy when it was not feasible to deliver this dose. And this was delivered to all metastatic sites, followed by pembrolizumab for 8 cycles in total, or 6 months. The comparator arm, this is no comparator, this is a single arm study, but we did compare to the historical comparator of pembrolizumab alone in Keynote 427. And the outcomes were safety and efficacy. There were 30 patients in total that were enrolled in the study, and there were 83 oligometastases irradiated in total. So this is a higher burden of disease than we see in most studies of oligometastatic disease. This is 3 mets per patient. 77% of patients received SBRT, and 23% also received some conformal radiotherapy. There were 8 adrenal metastases, 43 metastases were in the lung, which is very common, but there were also bone and soft tissue lesions irradiated. Most patients had no prior systemic therapy at 3/4. Other patients had had prior metastatectomy at about 1/3, and there was TKI and IL-2 also used in some of this cohort. From an efficacy perspective, the median follow-up we were reporting was 2.3 years, and the disease control rate was, which we defined as the duration of pembrolizumab being complete response, partial response, or stable disease for greater than 6 months, was very high at 83%. These are 2 waterfall plots. In the middle is a per patient waterfall plot, and on the right is a per lesion waterfall plot, broken down by yellow by those lesions receiving SBRT, and in blue, those receiving conformal radiotherapy, conventional radiotherapy, I should say. And these are deep waterfall plots that are clearly not just immunotherapy alone. This is clearly a combination of both immunotherapy and radiation. And in fact, the complete response rates of 40% were some of the highest that we can see in the literature. From an efficacy perspective, the median progression-free survival was 15.6 months, and the median overall survival and median duration response was not reached. The freedom from local progression at 2 years was 92%. And these are three of the Kaplan-Meier graphs there: progression-free survival, overall survival, and percentage of responders, duration response on the right. So the conclusions and takeaway from that study is that the combination of SABR and short-course pembrolizumab in oligometastatic renal cell carcinoma is both well tolerated with excellent local control, and the observed PFS that we saw at 15 months and objective response rate of 63% is roughly double of what is seen with the Keynote 427 study of pembrolizumab monotherapy, with a PFS rate of 7.1 months and the objective response rate of 34%. The caveat to this is that it's likely that the Keynote population had a higher burden of disease at baseline. There was also durable responses and encouraging PFS that were observed with this approach, and this warrants further investigation. If you look at what we know from the prospective trials in oligometastatic RCC, if you look at surgery in this context, we know one thing, that the addition of TKI is not beneficial. There's one randomized trial called the RESORT trial, which is one of the few prospective studies in the surgical setting, which looked at sorafenib versus methotrexate alone. And this did not show benefit of the addition of TKI. There's one abstract-only study, which is pazopanib versus placebo, and this also is concordant, no benefit for the addition of TKI. If we look at the prospective trials of SABR, on the other hand, we know that it can be delivered in lieu of systemic therapy, that it can delay the next line of systemic therapy in oligoprogressive disease, and that it's safe and effective when combined with short-course immunotherapy. So we have to try to decide between the two treatment approaches. The advantages of metastectomy versus SABR, if we look at stereotactic radiotherapy, we know that it's non-invasive, it has low toxicity, does not interrupt drug therapy, and potentially has synergy with immunotherapy. From a surgical perspective, it's important that we use surgery when we want to have tissue confirmation, perhaps in the first instance.
I've just lost power. I'm hoping you can hear me, and if you can't, let me know. So surgery basically has the advantage of tissue confirmation, and we should use this when we're having the first presentation of metastatic disease, and also when we need the rapid palliation of mass effect. So patients who have basically some kind of neurology, such as spinal cord compression, and require rapid palliation, surgery is the optimal approach. To address further reading, we have this study from Muhammad Ali et al., European Urology, has a really nice overview of the different approaches for metastasis-directed therapy. So in summary, radiotherapy for renal cell carcinoma, if we look at renal cell carcinoma, it is not radioresistant from ablative doses of radiation, in my opinion. SABR for primary RCC is an emerging field. There are unique competitive advantages for radiotherapy, and SABR for oligometastatic RCC is now established in prospective trials in lieu of systemic therapy for oligoprogressive disease and in combination with immunotherapy. Please do consider joining the IROC prospective registry. Hopefully together we can make a difference in this field in the context of primary RCC as well. I'd like to thank you all for your attention, and we'll open up for questions at this point. Thank you.
Thanks, Shankar. That was an amazing overview of a very rapidly evolving field, and again, applaud you and your investigators, including those in Canada who are leading the way around and change the improvement of management of these patients. I do want to thank formally Tolmar for sponsoring Dr. Siva's talk today. With our technical issues and jitters of getting started, I was remiss in forgetting to acknowledge both Jen Eggert and Jennifer Schindler for their help allowing Shankar to speak to us today. Yeah, I think your headphones were slowly dying on us, Shankar, and we were having a little trouble here. The pods work great. So let's open up. There's a Q&A I think you can see that if you click on the bottom, Shankar, the Q&A tab, and then there's some chats. If people want to ask a question, I can open your microphone. So just raise your hand. I can, if you prefer to answer your question or ask your question verbally, just raise your hand and I'll open up the talk that way. But maybe, can you see those questions, Shankar, on the Q&A?
I can, yeah.
Perfect.
Do you want me to read them out and reply?
Yeah, if you, yeah, just for the benefit, I'm sure everyone can see the Q&A questions, but so if you can do that, would be great.
Fantastic. I have a question. The opening one was from Professor Laurie Potts. So how is local control defined? Many, if not the majority of small renal masses are stable over time. So I think that's the first part of the question. I think just to address that, one important factor to be clear is that many of the patients who are referred for SBRT or SABR have already failed active surveillance. So these are not patients that have small renal masses at the first presentation. SABR or an SBRT is a newer treatment and by rights should actually be justified in patients who have no other options at this point in time. And often the first option for small renal masses in patients who are otherwise medically inoperable should be active surveillance. And so the patients we see are not those who are suitable for active surveillance. Those are those who have failed active surveillance. The second point is the majority of patients are actually not small renal masses. We mentioned the median size of 4.2 centimeters. So these are typically T1B and larger tumors. The second part of the question is, if local control was not confirmed for biopsy, is it possible that the higher rates of local control reflect indolent natural history of small renal masses? And this would be a fair criticism if we didn't have the long-term follow-up. So as we know, radiotherapy doesn't work in the same way that we consider for thermal ablation, which is a physically destructive treatment. In fact, we just wrote an editorial in the European Urology in the last couple of weeks, which I hope you can look at, which was titled the false premise of post-treatment biopsy in the context of SBRT for primary kidney cancer. And this is in response to a new paper from UT Southwestern. There's been multiple studies showing that there can be positive biopsies after kidney SABR, even at a year post-treatment. And these do not reflect ongoing responses of these tumors over time. This is something that we've seen in radiation oncology in multiple different cancer types. You know, in the brachytherapy setting or in prostate radiotherapy setting, we've been trying to do post-treatment biopsies to assess response, and this does not correlate to PSA kinetics. We stopped doing this in the context of lung cancer some 20 years ago, head and neck cancer, post-treatment dissection, anal cancer, post-treatment dissection, as well as other tumors as well, cervical cancer. It's clear that radiation causes cell kill over time, and post-treatment biopsy is probably not the optimal response assessment. And in fact, response assessment is only a surrogate for a long-term outcome. So really what patients care about is overall survival and cancer-specific survival and lack of progression. So as long as we can prove this over time, and when we have data sets with median follow-ups of greater than 5 years, I think it's pretty evident that this is a reasonable surrogate. I hope that answered the question, because it's obviously a very eminent person asking the question. I'm going to switch over to a question from Patrick Chung. Great talk, Shankar. How do you choose between delivering 25 to 26 gray in single fraction versus 42 and 3? And then obviously a very common Canadian and North American approach is that 5 fraction approach, ranging between 35 and 45 gray in Patrick's question. So it's simple for us. We made a very pragmatic choice that when we're looking at a single fraction, we're just going to draw the line at T1A tumors. It's very easy to remember that. Anything less than 4 centimeters, we treat with a single fraction of 26 gray. And in fact, when talking about a competitive option with perhaps thermal ablation, this is what we want to be presenting. So a patient has a choice of thermal ablation, which is invasive, may require an anesthetic, but is still a one-stop shop, versus a totally non-invasive approach, which is just a single treatment and a one-stop approach. That's why we draw the line at 4 centimeters in our institution. The 42 gray and 3 is for larger tumors greater than 4 centimeters in size. I think that's also seems to be very effective. We don't use 5 fractions in our group, and I suspect, it will really depend on time. We'll have to do more analyses as to see what the optimal approach is. But certainly, I'm hoping to show in Astro this year good outcomes with both the 42-3 and the single fraction approach in a multi-center trial.
Shankar, just on that point, sorry to interrupt. Why do you, maybe you're just speculating, but in prostate cancer, we've seen that a single fraction really isn't enough based on our Jared Morton's HDR monotherapy experience, but we're seeing the opposite in renal cell. What do you think that is? Is it because of the radiobiology differences between the tumors or what?
Yeah, I do think I suspect it's the radiobiological differences, and also the fact that renal cell carcinoma is so vascular. And I think these big single fractions are very disruptive for the tumor vasculature and the neovasculature and causes a lot of endothelial cell kill. So it might be that. I think it's consistent because there is data from Memorial Sloan Kettering as well that have compared high dose single fraction in the metastatic setting. So 24 gray in 1 fraction versus the same 24 gray in 3 fractions, showing better outcomes with the single fraction approach. In the kidney, I think it actually has a very unique advantage because the kidney tumor is often surrounded by normal kidney parenchyma. And the kidney tumor, if you believe the alpha beta ratios for the CARCI1 A498 cell lines, which is 2.6 gray and 6.9 gray, these are really thrive on big doses per fraction, whereas the surrounding normal kidney parenchyma is probably a higher alpha beta ratio. So by using very, very big doses per fraction, we're taking advantage of that, sparing kidney parenchyma and getting more dose in towards the tumor. So I can only speculate this because, this is not high-level randomized prospective data as yet, but it's worth actually testing this out in a prospective trial. And we really should go ahead and do that.
Thanks so much.
The second part of Dr. Chung's question is also when giving single fraction SBRT at the kidney, what do you limit the small bowel dose at? So there are 2 components for the small bowel dose. And in fact, everyone can find this. This is publicly listed in BMC Cancer. We have the TROG 1503 Fast Track 2 protocol listed there. So there's 2 things. I look at the total dose that covers the circumference of the small bowel. We limit that to 13 gray or less. And then the max dose area. So we try to reduce that to, it's actually eye-wateringly high, but to a point dose of around about 24 gray. One thing that's important, we also add a little buffer of margin, so 3 millimeter PRV, and apply these dose constraints to that area. Another question from Dr. Sean Malone about the upper size limit and comments on techniques, VMAT versus CyberKnife. That's a very interesting question. So the upper size limit, I think, is not defined as yet. So we're treating very big tumors on clinical trials such as CytoShrink, which is a Canadian trial, and also look at the NRG GU12 in the context of cytoreductive radiotherapy in the immunotherapy setting. So these are tumors I've treated up to 12 centimeters, 13 centimeters in size. So for the Fast Track 2 trial, we had a pragmatic upper size limit of 10 centimeters. I'm not sure we found the upper size limit just yet, but I think this is a space to be observed. I think with these very high doses, I'm probably comfortable about the 8 to 10 centimeter mark. In terms of technique, one particular issue with CyberKnife is a requirement for, well, typically the requirement for a fiducial marker insertion. I think this may be an issue for renal cell carcinoma because of the very vascular tumor, and inserting fiducial markers is probably not ideal in this context. So perhaps a conventional linear accelerator might be just enough using VMAT in this context. We have a question from Dr. Martin Smoragewicz. I'm so sorry, I probably butchered your surname. Smoragewicz, let me try that. So is there any radiobiology difference between clear cell and non-clear cell? And if so, how might that affect SABR in non-clear cell? So one of the issues is that the population of non-clear cell is so small. In general, it's 10% of what we see in kidney cancer anyway. And in the context of SBRT, the number of data sets that we have available for the non-clear cell population is very small. IROC at the moment is trying to investigate this. We're pooling some data. Dr. Muhammad Ali is my PhD student, is pooling some data in non-clear cell to try to address this issue, to seeing whether papillary or chromophobe might have the same kind of outcomes. Anecdotally, it seems to be the case, but I don't think we have the answer to that yet. Will Chu, thank you for the comprehensive talk. What is your approach for bilateral multifocal RCC, targeting, motion management, and delivery? So this is an unusual scenario, but it does crop up. Ideally, I think, personally, we should take a hybrid approach when we're looking at multifocal bilateral disease. I prefer to have one surgical approach for one kidney and potentially use a more focal approach for the other kidney, because it may be that when approaching that bigger tumor typically we're addressing one larger tumor in one kidney and a smaller tumor in another kidney. When addressing that a larger kidney, it may become evident that you can't do a partial nephrectomy, and in fact the entire kidney needs to come out. And in that context, it's really important to be able to treat that smaller kidney with a focal approach. So typically I like to use hybrid approaches, and then when we have to use SBRT for both, luckily, because the organs are so far apart, we don't see a lot of overlap, but I do try to use more advanced motion management approaches such as XL breath hold or gating approaches in these tumors. Generally speaking, we don't have to use something so fancy, I find. We did a study prior to enrolling in our first clinical trial, looking at 71 patients with normal kidneys having 4D CT. 3/4 of the patients had kidney motion of less than 3/4 of a centimeter. It's a small population of patients that have a tumor motion of greater than 1 centimeter that we need to keep an eye on for advanced motion management techniques. But yeah, generally speaking, that's kind of the approach we take. Anonymous attendee asked the question, any plans in future studies to estimate the alpha-beta ratio of renal tumors and parenchyma? Good question, not from me. I'm sure other people will potentially look at that. I don't think the alpha-beta ratio itself is an unknown in kidney cancer. There are multiple cell lines that have had addressed this. It is a low alpha-beta ratio. We know this already. But I think the range is somewhere between that 2.6 to 6.9 based on the human cell lines that we know. Dr. Sean Malone's asked a question about role of upper tract TCC. So upper tract TCC is a very interesting scenario. Actually, it responds beautifully to SBRT. These things shrink away dramatically. I just saw a letter today from one of my colleagues, actually one of my colleagues who's been to Toronto before, Professor Nathan Lawrenchuk, you might well know, who's just discharged a patient who had a very large 90-year-old patient who had a primary TCC of the RCC pelvis, 5 centimeter tumor that shrunk away beautifully and has had this stent out just today. So these tumors respond well, but the issue with TCC is that they have a propensity for distant metastasis. So it's not often the local treatment that matters, it's the distant recurrence, which is the issue. Dr. Hans Schön asked the question, is there a minimum SBRT dose needed for metastatic deposits? I think there is. I think there's a yes. There's a big push for hypofractionated doses of 8 gray by 3 in the immunotherapy era. This is largely led by multiple studies from the Weill Cornell Center, looking largely in the context of breast cancer and lung cancer. However, I don't think that's actually good enough dose. There is data from MSKCC, as I mentioned, that compared this 3 by 8 versus 24 in 1, showing pretty definitively that RCC responds better to these high doses per fraction. So I suspect there is a minimum dose, and it's not that hyperfractionated radiotherapy. It needs to be a little bit more punchy. And in fact, we see this when looking at even palliating primary RCC lesions. A common dose in PETA-MAC in Australia is 36 gray and 12. That's a very high dose palliative regimen, but lower dose palliative regimens such as 20 gray and 5 really don't work in RCC. We need to be much more punchy than this. So yeah, I think it's high dose per fraction. Getting there, Dr. Patrick Chung, that's the last question on the list, which is when you prescribe kidney SABR, are your plans very hot inside, or are plans relatively homogeneous within the PTV, especially if the bowel is closer within the PTV. So one major bugbear I have is people prescribing homogeneous SABR for kidney. This is not prostate cancer where we're trying to treat homogeneously with SBRT. This is the old school SBRT, or where we're trying to do prescribing at the isocenter and make it really hot middle. Yeah, so typically all the cases that Peter make receiving SABR, proper ablative SABR, is a peak dose of 125%, and that's uniform. We accept up to 143%, and generally they all have this. The issue when you have bowel close by, particularly when the PRV, we always apply a 3 millimeter PRV to individual loops. When that overlaps with the PTV, we deliberately underdose the edge of the tumor. And that's okay, because I think that high dose gradient to that peak dose area probably compensates for that loss of coverage.
Fantastic.
Thank you.
Shankar, that was an amazing overview. I really appreciate, like I said, the comprehensiveness of the talk and all the work that you've done. So thank you so much for tuning in. Thank you everybody for getting up and hearing Shankar. It's our pleasure to host you, and hope to see you in person. Are you going to Astro this year?
Estro, I'll be there. Will
All
you?
right, I'll be there.
I'll see you there.
I'll see you in Vienna next week.
Wonderful.
Awesome.
Thanks so much
Thank
for
you,
the
everybody.
questions as well.
Yeah, exactly. See you, everyone. Thanks for tuning in.